Hey there! I'm thrilled to walk you through patient safety concepts today. This isn't just another boring lecture, it's critical knowledge that'll help you pass your certification exam and keep those tiny NICU patients safe. All right, here's our game plan. We're going to break down patient safety into manageable chunks that'll stick in your brain. You'll only see a few questions related to patient safety, which isn't much, but they are usually easy score boosters. First, we'll cover fundamental safety concepts, then move into high reliability principles. We'll also tackle communication tools that examiners love to test, error classification systems, and NICU-specific challenges. Remember, in the NICU, we're dealing with our most vulnerable patients who can't speak up for themselves, which is why this content is so important both for the exam and real practice. Let's start with the basics. Safety isn't just a nice to have. It's literally the foundation everything else sits on. Think about it this way. If safety isn't solid, nothing else matters. Quality care simply can't exist without safety. The exam loves to test whether you understand the difference between a system-focused approach versus a person-centered approach. Old school thinking was all about blaming individuals when things went wrong. Modern safety science focuses on systems and processes. You'll definitely need to know the Donabedian Triad. Structure leads to processes which create outcomes. Structure includes things like staffing and equipment, processes are your protocols and procedures, and outcomes are what actually happens to patients. Now for the good stuff, high reliability organizations are those that handle risky, complex situations without making major mistakes. What makes them so special? The exam loves to test this concept, particularly preoccupation with failure. What does that mean? HROs constantly look for potential problems before they happen. They're paranoid in a good way. They don't dismiss small errors because they know small problems can snowball into disasters. The other principles matter too. Reluctance to simplify means digging deeper to understand complex issues. Sensitivity to operations means paying attention to what's actually happening on the front lines. Commitment to resilience means bouncing back after problems. Let's talk about categorizing safety events because the exam will definitely test you on this. Think of it as a spectrum from minor to major. Near misses are caught before reaching the patient, like almost giving the wrong med but catching it. Precursor events reach the patient but cause minimal or no harm. This category trips up a lot of test takers. Serious safety events or sentinel events cause significant harm. Think wrong site surgery or medication overdose. Never events are those serious preventable events that should literally never happen, like operating on the wrong patient. The exam frequently tests whether you can identify which category a scenario falls into, especially precursor events. Remember that pyramid relationship? For every serious error, there are dozens of precursors and hundreds of near misses. Culture isn't just a buzzword. It's the environment that either promotes or prevents errors. The exam contrasts two approaches. The person-centered approach is outdated. It focuses on who messed up and usually leads to blame, shame, and hiding mistakes. The systems approach is what we aim for today. It recognizes that humans are fallible and builds systems to prevent errors despite human limitations. Just culture is the sweet spot. It balances personal accountability with understanding system issues. Now, let's get specific to the NICU. Know these stats for the exam. A whopping 47% of NICU errors are medication-related. That's nearly half. Patient misidentification accounts for 11%, diagnosis errors for 7%, and treatment administration errors for 14%. Why so many medication errors? Well, think about it. Weight-based calculations, decimal points that matter, multiple dilutions, and patients who can't tell you when something feels wrong. Speaking of medication safety, let's dig deeper. What makes NICU patients especially vulnerable to medication errors? First, we're constantly doing individualized weight-based dosing calculations, sometimes with extremely premature babies weighing less than a pound. When a decimal point moves, it can mean a 10x overdose. Second, neonates have wild pharmacokinetic variability. Their immature organs process drugs differently. Third, our patients can't tell us if they're experiencing side effects. We have to catch them ourselves. Finally, many medications aren't even formulated for neonates, requiring complex dilutions. Let's talk communication tools. The exam absolutely adores these. SBAR is the gold standard. Situation, background, assessment, recommendation. This structured communication approach is tested more than any other tool. You might think TeamSTEPPS is about dividing tasks, but that's a common misconception the exam exploits. It's actually a framework for improving communication through leadership, monitoring, mutual support, and communication. Know your communication strategies like checkbacks. I'll give 0.2 milligrams of morphine. 0.2 milligrams of morphine, got it. Call-outs, announcing critical information, and stop the line, pausing when something seems wrong. In the exam, you may see questions that present scenarios where these tools either prevent or fail to prevent errors. Building safety into your systems is key. The exam tests your knowledge of evidence-based bundles, grouped interventions that work better together than separately, standardized checklists which reduce reliance on memory and ensure consistent care, real-time surveillance actively looking for potential problems, transparent disclosure openly discussing errors with families. Here's where we get into the weeds of making care safer. These methodologies appear frequently on the exam. PDSA cycles, Plan, Do, Study, Act, small tests of change before broader implementation. Root cause analysis, systematically identifying what caused an error. Lean, eliminating waste in processes. Six Sigma, reducing variation to prevent defects. The exam may present scenarios and ask which methodology would be most appropriate. Remember that RCA is retrospective after an error, while PDSA is proactive improvement. Infection prevention deserves special attention because it's both heavily tested and critically important in the NICU. The key elements to know for the exam are hand hygiene, always the cornerstone and first defense. Central line bundles, including proper insertion techniques, maintenance, and daily necessity reviews. Ventilator bundles, including head of bed elevation and oral care. Antibiotic stewardship, using antibiotics appropriately to prevent resistance. The exam usually has a question about hospital-acquired infections, particularly around recognizing which organisms are almost always nosocomial versus those that could be transmitted from mother to baby. Technology can be a double-edged sword, and the exam tests your understanding of both benefits and risks. Know these technologies and their safety impacts. Computerized provider order entry reduces prescription errors by eliminating handwriting issues and providing dosing guidance. Barcoding prevents patient misidentification, crucial in the NICU where patients can't identify themselves. Smart pumps have built-in safety limits to prevent massive overdoses. EMRs improve information access but can create their own safety challenges if poorly designed. The exam might present scenarios asking about which technology would best address a specific error type. Know the strengths and limitations of each. Simulation deserves special attention because it's becoming increasingly important in neonatal care. The exam tests whether you understand team training for high-risk, low-frequency events, like massive pulmonary hemorrhage or cardiac arrest, debriefing to identify improvement opportunities. This is where the real learning happens. Communication practice, testing how teams function under pressure. The exam might present scenarios asking about the best way to prepare teams for rare emergency situations. Simulation is almost always the correct answer over didactic training alone, especially for procedural skills and team communication. A neonatal ICU has experienced 3 unplanned extubations in the past month. The nurse manager wants to implement a quality improvement initiative to reduce these events. Which approach would be most appropriate for testing a new prevention protocol? A. Root cause analysis, RCA. B. Lean methodology. C. Plan, Do, Study, Act, PDSA. Cycles. This question is testing your knowledge of quality improvement methodologies and their appropriate applications in the NICU setting. PDSA cycles are specifically designed for testing and implementing new protocols in a systematic way. The approach involves planning a change, plan, implementing it on a small scale, do, Analyzing the results, study, and then acting on what was learned, act. This makes it ideal for testing a new extubation prevention protocol because it allows for small-scale testing before full implementation. Root cause analysis, RCA, is retrospective and used after an adverse event has already occurred to determine what went wrong. It wouldn't be appropriate for implementing a new protocol. Lean methodology focuses primarily on eliminating waste in processes rather than testing new interventions. While it might be useful later, it's not the best first approach for this specific scenario. During a medication administration in the NICU, a nurse notices that the smart pump alarm activates when programming a dopamine infusion. After double-checking the calculation, the nurse determines the dose is correct, but exceeds the soft limit in the pump. Which of the following best represents the type of safety event that was prevented? A. Sentinel event. B. Near-miss. C. Precursor event. The correct answer is B. Near-miss. This question is assessing your understanding of safety event classification. A near-miss is defined as an error that was caught before reaching the patient. In this scenario, the smart pump alerted the nurse to a potential dosing issue, and verification occurred before administration to the patient. This represents a key safety mechanism working properly to prevent harm. A sentinel event involves death or serious physical or psychological injury or risk thereof, far more serious than what was described. A precursor event is one that reaches the patient but causes minimal or no harm. Since the medication was never administered to the patient, this cannot be a precursor event. Understanding these classifications is crucial for proper reporting and for developing system improvements based on safety data. During a busy shift in the NICU, a nurse practitioner needs to communicate critical laboratory results to the attending physician. Which communication technique below would be most effective in ensuring clear transmission of this important information? A. SBAR, Situation Background Assessment Recommendation. B. DESC, Describe, Express, Specify Consequences. C. Two-challenge rule. The correct answer is A. SBAR. This question is testing your knowledge of standardized communication tools. SBAR provides a structured framework for communicating critical patient information between healthcare providers. It ensures all relevant information is conveyed clearly by organizing it into the current situation, relevant background information, the communicator's assessment, and recommendations for action. This is the gold standard for clinical handoffs and critical communications in healthcare settings. DESC is a conflict resolution method used when there's disagreement, not for routine clinical communication. The two-challenge rule is used when a team member needs to voice a safety concern twice if it's been ignored the first time. It's not a comprehensive communication tool for conveying critical information. The Joint Commission has identified communication failures as a leading root cause of sentinel events, making standardized communication tools like SBAR essential for patient safety.